When we think about the side effects of chemotherapy, we generally picture, um, you know, the visible storm damage.
Right, the obvious stuff.
Yeah, exactly.
Yeah.
We think about hair loss, we think about nausea, fatigue. But according to the research we're looking at today, for up to 75% of breast cancer survivors, one of the most devastating side effects isn't actually happening to their hair or their stomach.
No, it's not.
It's this silent structural collapse happening in their pelvic floor.
Yeah, and it's a profound shift that happens quietly, entirely overshadowed by the immediate loud crisis of a cancer diagnosis.
Right.
By the time a patient realizes what is actually going on, the structural integrity of their body has been fundamentally compromised.
Wow. Well, welcome to this deep dive, especially to you, the learner. Whether you're here to understand your own body better, or maybe you are supporting a loved one through recovery, or you're just inherently curious about the hidden biomechanics of human biology.
Which is fascinating on its own.
It really is. Our mission today is to answer a very specific yet incredibly vital question. Can chemotherapy-related menopause actually worsen laxity symptoms in the pelvic floor?
It's a question that it forces us to connect oncology, endocrinology, and biomechanics all together.
Yeah, it's a lot.
It is. We are going to look at the intersection of how cancer treatments alter the basic building blocks of human tissue.
And we have a fantastic stack of sources guiding us today to do just that. We're pulling from clinical guidelines published by the British Menopause Society, deep dive research into collagen dynamics, physical therapy protocols from Franciscan Health, and extensive oncology reports focusing on breast cancer survivorship.
Yeah, we're going to synthesize all of this to give you a clear picture of what is happening at the cellular level and, more importantly, how that translates to the physical reality of living in that body.
Okay, let's unpack this. Let's start with the catalyst for all of this. How does a drug designed to shrink a tumor in the breast end up causing a structural collapse in the pelvis?
Right. So to understand that, we have to look at the domino effect that chemotherapy triggers in a person's hormones.
Okay.
Chemotherapy drugs are essentially like search and destroy missiles programmed to target fast-growing cells.
Because that's what cancer is, right? Just rapidly dividing cells.
Exactly. That is how they effectively attack a rapidly dividing cancer. But they're systemic, meaning they travel through the entire body, and they aren't, perfectly precise.
They hit other things.
Yeah. They end up irritating all the mucous membranes they encounter.
Which is why cancer patients so often get painful sores in their mouths or have severe digestive issues, right? The mouth and the gut are lined with mucous membranes.
Yes, exactly. And the vulvar and vaginal tissues are also mucous membranes.
Oh, right.
So they get hit with that exact same systemic inflammation and cellular irritation. But the damage goes much deeper than surface-level inflammation.
How so?
Well, chemotherapy frequently causes direct toxic damage to the ovaries themselves. When the ovaries are damaged to the point of shutting down, it leads to premature ovarian insufficiency, or POI.
So basically, the body is just thrown into sudden early menopause. The natural production of estrogen just plummets overnight.
Yeah, it plummets. And for a breast cancer patient, that sudden drop in estrogen is often deliberate and aggressively maintained.
Wait, why is it deliberate?
Because many breast cancers use estrogen as a fuel source to grow. So oncologists use adjuvant endocrine therapies to starve the body of that hormone.
Oh, I see.
They'll prescribe drugs like tamoxifen, which binds to estrogen receptors to block them, or aromatase inhibitors, which, they stop the body's peripheral tissues from producing any remaining trace amounts of estrogen.
I like to think of estrogen as the maintenance crew for your pelvic tissues.
That's a good way to put it.
Yeah, they show up every single day, they inspect the cellular walls, they fix the micro tears, and they keep the tissue strong, thick, and flexible.
Right.
But when chemo damages the ovaries and hormone blockers literally lock the doors, that entire maintenance crew is sent home indefinitely. The building just starts to fall into disrepair.
And that disrepair has a clinical name. It's called genitourinary syndrome of menopause, or GSM.
GSM, okay.
Yeah. Without the maintenance crew, the tissue literally deteriorates. The vaginal walls thin out dramatically, they lose their natural elasticity, and the vascular network shrinks, meaning blood flow to the entire pelvic region just decreases.
And unlike hot flashes, which are deeply unpleasant but often fade away as the central nervous system eventually adjusts to the lack of hormones.
Right, they do often fade.
The sources point out that these structural pelvic symptoms are chronic. They are progressive.
Mm.
If you don't actively intervene, they just keep getting worse.
If we connect this to the bigger picture, they don't naturally resolve because the underlying mechanism, the estrogen deficiency, is permanent.
Which is why we need to examine the actual materials this maintenance crew is working with. What is the physical architecture of the pelvis, and why does it fail so catastrophically without estrogen?
Okay, let's visualize the pelvic floor. It is essentially a thick, three-layered hammock made up of nerves, muscles, tendons, and ligaments.
Just a giant hammock holding everything.
Exactly. It extends all the way from the pubic bone in the front to the tailbone in the back. And this hammock has an incredibly heavy, demanding job. It has to physically support the bladder, the rectum, the uterus, and the vagina.
Keeps all of those organs suspended and locked into their proper anatomical positions.
Right. And the material that gives this hammock its strength, its ability to hold all that weight day in and day out without sagging, is collagen.
Ah, collagen.
Specifically, the hammock relies on fibrillar collagens known as types 1, 2, and 3. But here is the most profound biological detail in the research.
Okay, what is it?
The estrogen doesn't just float around nearby. There are actual estrogen receptors located directly inside the nuclei of the pelvic connective tissue.
Wait, directly inside.
Yes. They are physically embedded in the very ligaments and the levator and stroma that hold everything up.
Wait, so the ligaments themselves are directly wired to respond to estrogen?
Yes. They are literally listening for it. When estrogen binds to those receptors inside the ligament, it signals the cells to produce high-quality, dense collagen, specifically collagen type I.
Type I.
Yeah. This is the heavy-duty fiber that gives ligaments their tensile strength.
So if collagen type I is like the steel rebar inside a concrete foundation, what happens when the maintenance crew leaves and the estrogen signal stops?
The body panics and tries to compensate. The ratio completely flips. The production of that strong collagen I drops off a cliff, and the tissue starts replacing it with collagen the third and 4.
And are those weaker?
Much weaker.
Yeah.
Those types of collagen are naturally found more in skin and blood vessels. They are much more flexible and highly prone to stretching.
So the body is essentially replacing the steel rebar in the foundation with, like, plastic straws.
Plastic straws, exactly.
It still takes up space, but the moment you put weight on it, it snaps or stretches out of shape.
Right. But this raises an important question. Isn't this just gravity taking its toll?
Yeah, I was wondering that. Women who haven't had chemo get prolapse just from aging or from the physical trauma of childbirth.
Exactly. Are we absolutely sure the chemo-induced menopause is actually changing the physical material? Or is it just the normal wear and tear of life?
Right. Is it just getting older?
It's a vital distinction to make, and it's one researchers wanted to definitively answer. Yes, gravity in childbirth strain the pelvic floor, but the material itself is fundamentally altering purely because of the lack of estrogen.
Purely the estrogen.
Yes. We know this from a really illuminating preclinical study on ovariectomized rats.
The rat study. The methodology here is fascinating.
It really is. Researchers surgically removed the ovaries of these rats, completely depriving them of hormones to simulate abrupt menopause.
Which mimics what happens to the chemo patients.
Exactly. Predictably, their pelvic connective tissue rapidly degraded. The tensile strength plummeted. But the researchers didn't stop there. They wanted to see if the process was reversible.
Okay.
So they treated these rats with low-dose vaginal estrogen.
And the results were drastic. It wasn't just a slight plumping of the tissue.
No, not at all. They saw a massive, verifiable increase in total collagen content. More importantly, they saw an increase in mature structural collagen.
The rebar came back.
Yes. And this is where the cellular mechanics get really interesting. The estrogen caused a massive spike in specific collagen processing enzymes, namely LOX and BMP1.
Okay, let's break those down because throwing around acronyms like LOX and BMP1 can get a little dense.
Fair enough. Think of BMP1 as the factory worker that prepares the raw collagen material, getting it ready for assembly.
Okay, the prep guy.
Right. And LOX, which stands for lysyl oxidase, acts like the welder. It physically cross-links the collagen fibers together.
And without the welder.
Without that cross-linking, the fibers just slide past each other and tear under pressure. When the LOX enzyme welds them together, they form an unbreakable grid.
I see. So without estrogen, the body essentially fires the welders.
Yes, the welders are gone.
The raw materials might be floating around, but nobody is binding them together to make them strong. When they gave the rats the estrogen back, the welders returned. And the tissue distensibility, its ability to stretch and return to shape without tearing, was completely restored.
Exactly. The biomechanical properties of the vaginal wall and pelvic support structures fundamentally rely on that hormonal signal.
So the hammock is fundamentally changing. It's losing its rebar. It's losing its welders. How does that translate to the patient's daily life? When does microscopic collagen degradation become an actual mechanical failure?
Right, so in the clinical world, this manifests as pelvic organ prolapse, or POP.
POP.
Yeah. When those weakened, unwelded tissues stretch and fail, the organs they're supposed to be supporting literally drop. The bladder, the uterus, or the rectum descend and visibly press against the vaginal wall.
Oh, wow. And the symptoms described in the clinical literature are incredibly disruptive.
Very disruptive.
Patients frequently describe a feeling of intense vaginal heaviness. The phrase that comes up over and over again from patients is that it feels like sitting on an egg.
Which just sounds awful. It is a very uncomfortable, constant mechanical reality. And the secondary symptoms depend entirely on which part of the hammock gives way first.
Right, let's explore that, because it's not the same for everyone. If the front wall of the vagina fails, it drags the bladder down with it.
Yeah, and the physical dragging of the bladder creates this constant fake urgency to pee.
Psychic urgency.
Yeah. The patient feels an intense, overwhelming need to empty their bladder immediately, but when they try, very little comes out.
Because the bladder isn't actually full.
Exactly. The bladder itself is practically empty. It's the physical stretching of the nerves that is triggering the urgency signal.
Oh, that sounds miserable.
Oh.
And conversely, if the back wall of the vagina falls, it affects the rectum. It causes a pocket to form in the weakened tissue, leading to severe stool trapping.
Right. The physical mechanics of a standard bowel movement are completely disrupted.
Which leads to some pretty extreme measures.
It does. The guidelines note that this specific type of prolapse often forces patients to resort to splinting.
Splinting.
Yeah, that means they have to physically push in or around the perineum or the vagina with their own fingers just to manually straighten the rectum and adequately empty their bowels.
If you're listening to this and you've gone through chemo, think about how confusing and isolating this must be. You might feel like you constantly have a severe urinary tract infection when the lab tests show you don't.
Right, the tests come back clear.
You might think your digestive system is failing, but it's not an infection, and it's not a digestive disease. It's physics. It's an organ dragging down because the foundation gave way.
And that highlights why proper diagnosis is so crucial. Menopause alone causes irritative bladder symptoms because the tissues thin out and become hypersensitive.
Sure.
But prolapse adds a literal physical obstruction to the mix. It is an organ that has moved out of its anatomical position.
Okay, I'm stuck here. We know the tissue is mechanically failing. A standard doctor might hear a complaint about pelvic floor weakness and just say, oh, go home and do your Kegels.
Oh, we hear that all the time.
But that can't possibly fix a torn, estrogen-starved hammock, can it?
No, not only will it not fix it, but simply doing Kegels can actively make things worse if the pelvic floor is already in a state of dysfunction.
Wait, really? Why is that?
Well, the research from Franciscan Health and the oncology reports detail that pelvic floor muscles in breast cancer survivors are demonstrably weaker than in the general population.
Okay.
But it is not just simple weakness. Treatments like pelvic radiation and systemic chemotherapies leave behind physical trauma.
Like scarring.
Yes.
Yeah.
We are talking about soft tissue tightness, rigid scarring, and actual nerve damage. The muscles often react to the pain and the organ prolapse by clenching in a permanent spasm to try and hold everything up.
Oh, I see. It's like if you have a massive painful knot in your shoulder, you don't try to fix it by doing heavy shoulder shrugs with dumbbells. You would just tear the muscle.
So massage the knot out first.
That is the perfect analogy. If the pelvic floor is locked in a tight, scarred spasm, aggressively doing Kegels is just tightening an already exhausted, rigid muscle. It leads to more pain and further dysfunction.
So if you tore a ligament in your knee, you wouldn't just flex your calf on the couch and hope for the best.
No, of course not.
You go to a sports rehab specialist. They would manually break down the scar tissue, teach you how to properly engage the surrounding muscles, and systematically rebuild the entire muscle group. Why should the pelvic floor be any different?
It shouldn't be. The universally recommended first pillar of treatment is specialized pelvic floor physical therapy.
And that's not just doing exercises at home.
No, it involves manual therapy performed by a clinical specialist to restore movement to those rigid, scarred tissues.
How do they actually do that?
They use biofeedback, which involves placing small sensors externally or internally to monitor muscle activity.
This helps patients actually visualize their muscle contractions on a screen, teaching them how to consciously release a spasm and then correctly engage the right fibers.
Oh, that's clever.
Yeah, and they also use specialized tools like pelvic wands and dilators to carefully stretch tight muscles and safely break down scar tissue. It is a comprehensive neurological and muscular rehabilitation.
And what's incredibly validating to read in journals like Supportive Care and Cancer is that breast cancer patients overwhelmingly wish they had been warned about these laxity risks sooner.
Yes, the lack of warning is a huge issue.
If they had known that chemo and hormone blockers would attack their pelvic floor, they could have proactively engaged in this exact type of physical therapy during or immediately after their treatment.
And being proactive can maintain core stability before the prolapse becomes severe. But, and this is a big but, physical therapy only fixes the muscles.
Right.
It breaks down the scar tissue and rebuilds the muscular strength, but it does not solve the root cause of the fraying hammock.
The maintenance crew is still locked out. The estrogen is still missing. Which brings us to the catch-22 of this whole scenario. Here's where it gets really interesting. The hormone dilemma. How do you safely treat estrogen loss in someone whose cancer was fueled by estrogen in the first place?
It's a very delicate balance. The guidelines from the British Menopause Society lay out a very strict step-by-step approach. For patients with hormone-sensitive cancers, the absolute first line of defense is always non-hormonal treatments.
Like moisturizers.
Exactly. We're talking about over-the-counter vaginal moisturizers and specialized lubricants.
And to be fair, they are great for what they do. They are the safest option because they carry zero risk of feeding a cancer cell.
True.
They temporarily increase surface moisture, they reduce friction, and they can make daily life more comfortable. But the medical literature is clear. They are just Band-Aids.
Yeah, they don't solve the structural issue.
Right. They do absolutely nothing to signal the body to make more collagen. They do not bring the welders back.
No, they don't. To actually repair the foundation, to signal the cells to make strong type I collagen again, the body needs estrogen.
Which is a terrifying concept for a breast cancer survivor.
Yeah.
If they take estrogen, aren't they risking a cancer recurrence?
And this is where we have to look closely at the different types of hormone therapies because they are not all created equal. The guidelines are very explicit about what is strictly contraindicated, meaning absolutely off the table for a breast cancer survivor undergoing active treatment.
Well, let's talk about the banned list first. The sources highlight drugs like vaginal DHEA and oral ospemifene. Why are those two dangerous?
Okay, so DHEA is a precursor hormone. When you apply it to the tissue, the cells absorb it and actually convert it into active estrogen and testosterone inside the cell itself.
Wow.
Yeah. For a breast cancer patient on aromatase inhibitors, introducing a compound that the body actively turns into estrogen is a massive biological risk.
That makes sense. And ospemifene.
Ospemifene is an oral pill. It is a selective estrogen receptor modulator, or a SERM. Because you swallow it, it circulates systemically through your entire bloodstream. The risk of that drug interacting with dormant breast cancer cells elsewhere in the body is simply too high during active adjuvant therapy.
So if systemic pills and precursor hormones are out, what is actually left?
The nuanced hope lies in ultra-low dose vaginal estrogen.
Ultra-low dose.
Yes. There is a massive pharmacologic difference between an estrogen patch that floods your entire circulatory system and a local therapy, like a microdose cream, a tablet, or a modern insert like Imvexxy that is applied directly to the vaginal tissue.
The goal with local therapy is minimal systemic absorption.
Yeah.
You are trying to treat the affected tissue directly without letting the hormones spill over into the general bloodstream where it could, theoretically reach breast tissue.
Yeah, precisely. Oncologists are increasingly viewing these highly targeted ultra-low-dose vaginal estrogens with cautious optimism. They are considered for patients whose quality of life is severely impacted by structural prolapse and who have totally failed to get relief from non-hormonal moisturizers.
Wait, let's think back to that rat study from earlier.
Right.
The researchers didn't just prove that estrogen restores the collagen and brings back the LOX enzymes. They tested different delivery methods.
Yes, they did.
And what they found completely changes the paradigm of how we view these local treatments.
It really does. The study proved that low-dose vaginal estrogen was actually far more effective at restoring collagen and improving tissue distensibility than systemic whole-body estrogen.
That is incredible. The treatment that is considered much safer for a breast cancer survivor because it stays local is actually the biologically superior treatment for fixing the structural damage in the pelvis.
It is a remarkable example of biological efficiency. By applying the hormone directly to the estrogen receptors embedded in the pelvic connective tissue, you get a stronger, more direct cellular response than you do by flooding the entire circulatory system and hoping some of it makes its way down to the pelvis.
Right. Why flood the whole house when you just need to fix the basement?
Exactly. It suggests that highly targeted local therapies aren't just a safety compromise for cancer patients. They might actually be the optimal gold standard way to rebuild pelvic connective tissue for anyone experiencing menopausal laxity.
So let's bring it all together. We started with the question, can chemotherapy-related menopause worsen laxity symptoms in the pelvic floor? And the answer unequivocally is yes.
Absolutely yes. Chemotherapy and hormone blockers aggressively shut down estrogen production. The estrogen receptors in the pelvic floor are starved of their primary signal.
And without that signal,
Without that signal, the enzymes that weld collagen together just vanish. The body stops making strong fibrillar collagen alloy and replaces it with weak, stretchy alternatives.
plastic straws.
Yeah. A pelvic hammock phrase. It loses its tensile strength, and the organs it supports drop, leading to prolapse and severe mechanical dysfunction.
But the takeaway here isn't doom and gloom. If you are listening to this and dealing with these symptoms, the takeaway is empowerment. Because once you understand the mechanics of the problem, you can leverage the mechanics of the solution.
You beautifully said.
By combining specialized, hands-on pelvic floor physical therapy to safely repair the scarred muscle function with careful, localized, low-dose medical treatments to restore the tissue's cellular instructions, it is entirely possible to rebuild that foundation.
It is.
Structural problems have structural solutions. You do not just have to grit your teeth and endure it.
And I want to leave you, the listener, with one final provocative thought to mull over. We have spent this entire deep dive discussing how estrogen receptors are physically embedded in the ligaments of the pelvic floor and how vital they are for signaling collagen production and enzyme activity. If the sudden loss of estrogen from chemotherapy degrades those specific pelvic ligaments so severely and so quickly, what might that mean for the connective tissues, the ligaments, and the joints in the rest of the body during the transition into normal menopause?
Oh, wow.
Perhaps estrogen is the unsung hero of our entire structural skeletal system, far beyond just the pelvis.
If it's acting as the rebar for the pelvic hammock, it's highly likely it is acting as the rebar for the rest of the house as well.
It is a profound area for future research.
Thank you for taking this deep dive with us today. Remember, the treatments that saved your life might have caused some hidden damage to the foundation, but with the right tools and the right specialists, that foundation can be rebuilt. Take care, and we'll see you on the next Deep Dive.